This is screen.
Very good evening to all my dear friends who have joined here today for this wonderful session. The most complex and most interesting part of obstetrics is this malpresentation. And I hope so everyone are interested to learn the different malpresentation, different positions, and also to learn how to present a case in your university exam. And today we have our mentor, Dr.Arun Poornesh, sir, who has recently completed his post-graduation in obstetric and gynecology. He is a diploma in orthopedics. He completed his diploma in orthopedics earlier, and he is interested in the field of infertility and laparoscopy. He has presented various interesting cases and research papers in national and international conferences. And today we are here for his guidance and for his mentoring for the case presentation presented by Anna Selva Grace, final year MBBS student from Meenakshi Medical College. Thank you so much, sir, for joining with us in spite of your schedule. And I hand over the session to you, sir. Thank you.
Thank you, Raghu, for giving me this opportunity. And I feel very happy to assist the student Hannah Selva while she's presenting the case. So nothing to worry. It's going to be an easy one. So let's start the case.
Anna, can you start the case presentation? I think she's having some network issues, sir.
Yeah, no problem. Let's wait.
Meanwhile, just
Sure.
yes, Anna, can you start the session? Can you start the
Yes,
presentation?
sir.
Yeah.
Yes, sir. Good evening to one and all. The case I'm presenting today
Anna, your
is
voice
a
is not audible.
26-year-old female, Mrs. Vidya, who studied till 10th standard. She's a housewife by occupation and she's from Kanchipuram. She belongs to the 5th socioeconomic class. Just a second. Is it fine now, sir?
Yeah, the audio is
Sir,
clear.
am I audible, sir? Yeah. Yes, sir. Okay, I'll start from the beginning.
Yeah.
So my case today is a 26-year-old female, Mrs. Vidya, who studied up to 10th standard. She's a housewife by occupation and she's from Kanchipuram. She belongs to the 5th socio-economic class according to the modified Kuppuswamy scale. The informant is the patient herself and the reliability is pretty good. She has had 11 antenatal visits so far, 3 visits in the first trimester, 2 visits in the second trimester, 4 visits in the second trimester, and 4 visits in the third trimester. She's a booked and an immunized case with Gravida 2, Para 2, Live 1, and Abortion 0. Her LMP was on 16th December 2022. She has regular periods with a 28-day cycle. Her expected date of delivery based on Negli's rule is on 22nd September 2023. Her gestational age as of today is 36 weeks and 5 days. Her chief complaints are 9 months of amenorrhea and she's come for routine antenatal checkup. History of presenting illness. She also has complaints of bilateral edema in both her legs. The onset of the edema is gradual. Yes, sir.
Yeah, just a second.
Yes, sir.
Is it okay for you if I interrupt while you're presenting the case so that you may know like what you have typed like that? Let me explain it a little bit.
Yeah,
So,
sure, sir.
if you go to the previous slide, you have written chief complaints, and in that you have mentioned like 9 months of amenorrhea for routine annual checkup. See, she's not coming with any like complaints as far as you told, like it's just 9 months of amenorrhea for routine. So you don't need to mention like a chief complaint. You can say like she presented with 9 months of amenorrhea for her routine and natal checkup. That's okay. Then when you go to the further previous slide, could you please go to that?
Yes,
Yeah. Okay, these are all fine. History of presenting illness, you have written like she has complaints of bilateral edema in both of her legs. But later on, you have written like she has come for her routine antenatal checkup. So like this is a little bit contradicting. So you can write all the positive findings, then the negative, and don't write the heading as chief complaints during antenatal care cases. Okay. So
okay.
then these are all fine. Then could you please go to the previous one?
Yes.
No, not the one. The previous slides, the first one. Okay. Yeah. So are you sure about this modified Kupasamy scale? Because in exam, they may ask deliberately, what is this scale? You should be knowing that class 1, class 2, class 3. Okay.
Yes, sir.
Like, do we know them? Like executives?
Yes, sir. The classification is based on 3 criteria. It is based on the income, per capita income of the
Okay.
family, the educational qualification, and the current occupation.
Okay.
So head of the family is considered the male if the male is present, and in the absence of the male, we consider the female as the head of the family.
Okay, that's okay. Or there's another thing where you categorize them as executives, professionals, skilled, semi-skilled. Nowadays, it's like they don't say as unskilled, they say as skilled, semi-skilled, and that's all. So the next page, can you go? Next slide. Okay. So do you know the like normal antenatal visits, how many times the woman should go during her pregnancy period?
Yes, sir. Up to 7 months, she's expected to go once every month. From then up to 36 weeks, it is once in every 2 weeks. And from 36 weeks till delivery, it's once every week, sir.
Okay. So it seems like she has gone many times. What is the reason for this?
So she's gone only once a month, sir. She's currently at 36 weeks.
Okay. Okay then.
Okay.
Next slide, please. Okay, these are all perfect. Coming to the, yeah, you can proceed with your presentation.
So history of presenting illness. He has a history of bilateral edema in both the legs. The onset of edema was gradual and it lasted for the past 2 weeks. The severity is moderate and it's aggravated by regular activities and exertion, and it's relieved on rest. There's no associated symptoms or no use of medications for the above complaints. History of present pregnancy. It's a spontaneous consumption 3 years after the first pregnancy and 5 years after marriage. She has used barrier contraception for spacing her pregnancy. She has no history of infertility.
Okay.
Into the first trimester history, she conceived spontaneously. Pregnancy was confirmed at home by UPT kit after she missed her periods. Dating scan was done in the first trimester, and the gestational age corresponds to the period of amenorrhea. There's history of morning sickness that is present. There's no history suggestive of hyperemesis gravidarum. She regularly took folic acid supplements in the first trimester. There's no history of fever with rashes or lymphadenopathy. There's no history of drugs intake, no history of radiation exposure, or no history of bleeding TB or spotting TB. In the second trimester, quickening was felt at 18 weeks. There's no history suggestive of gestational diabetes mellitus and pregnancy-induced hypertension. She was immunized with 2 doses of TD 4 weeks apart. An anomaly scan was taken. There was no detectable fetal anomalies. She continued to take
Not
iron for
TT. So we are using TD, tetanus
yes,
diphtheria. And one more thing we can use, alternative of TD. What's that?
TDAP,
PDAP. They are including what?
uh, tetanus and diphtheria toxins.
No. Tetanus, diphtheria, and what is the P? Acellular pertussis.
Okay.
Okay. Yeah.
So she continued her regular intake of iron, folic acid, and calcium tablets. OGCT was done and values were found to be within normal limits. The third trimester, she continued to perceive fetal movements and she continued to take her iron and calcium supplements. Growth scan was done and it was found to be appropriate for the gestational age, and she had no history of bleeding TB. Previous obstetric history, she's a Gravida 2, Para 2, Live 1, and Abortion 0. She delivered at 39 weeks. Term delivery was at a tertiary healthcare center. It was a spontaneous onset of labor and she delivered vaginally. There was no history of use of instruments or vacuum. Episiotomy was done. There's no history of PPH and blood transfusion. She delivered a live, healthy male baby weighing 3.2 kgs. The baby cried immediately after birth and it was boomed in with the mother within 24 hours. The baby was breastfed within 1 hour and was continued to be breastfed until 2 years of age. And the current age of the baby is 3 years.
Yeah, this is very nicely taken because the externals or the whomsoever you present in future, like in CME or wherever you are, they expect all these details from the previous obstetric history. What we previously write in a common outpatient department in OPDs is like just we'll put the first baby's birth weight, and if it's a boy or a girl, and delivered in a hospital or institution or at home, and alive or it's dead. That's all we write. But these many details are expected because the breastfeeding, the mother fails to breastfeed like spontaneously, only through some source of supplements to be given for some mother, who then you can find out whether she's having any malnourishments, if she's anemic, unable to breastfeed, doesn't know how to breastfeed the child, latching. There are many things which come in hand when you know about the previous pregnancies. Okay, Hannah, continue.
And in her postpartum period, there was no history of PPH or blood transfusion. There was no history of fever or pain. Lochia was healthy. There was no history of retention of urine, increased frequency of urine, or fever with chills. She resumed normal menstrual cycles 3 months postpartum, and she continued to have regular 28-day cycles.
Hannah, did you ask
her lactation history? She lactated and breast.
She started her regular menstruation 3 months postpartum. Hello? Can you hear me?
Yes, sir.
Can you hear me clearly? Okay.
Yes, sir.
Okay. You have mentioned like she has resumed normal menstrual
cycle. Yes, sir. You're audible, sir. Yes, sir.
So for how much months did she breastfeed? Did she have something called lactational amenorrhea? It seems that she has.
Yes, sir. She had. She had lactational amenorrhea for 3 months, sir.
Yeah. Okay.
Beyond that,
did she continue? Did she give an exclusive breastfeeding?
Yes, sir. The baby was exclusively breastfed for 6 months, sir.
6 months.
After which she started weaning with complementary feeds.
Okay. But still she resumed her periods 3 months postpartum. Okay, fine.
Yes, sir. Her lactation history, she lactated and breastfed within the first hour. There was no history of sore nipple, retracted nipple, or breast abscess, and she continued to lactate for 2 years. Contraceptive history, there was no use of barrier contraceptive to space the pregnancy, and there was no history of use of IUCD or other contraceptive pills, OCP pills. Menstrual history, age at menarche was at 14 years. She continued to have regular cycles cycles, which is a 5/28-day cycle. She uses 4 pads per day, and her LMT was on 16th December 2022. Marital history, she's married for 5 years. It's a non-consanguineous marriage. There's no history of planning or infertility, and there is history of use of barrier contraception.
Okay.
Medical history, there's no history of diabetes mellitus, hypertension, bronchial asthma, coronary artery disease, tuberculosis, epilepsy, or thyroid disorders. History, in surgical history, we do not have any relevant surgical history. Again, in family history, there's no relevant family history. Personal history, she consumes mixed diet. She has normal appetite, normal bowel and bladder habits, normal sleep pattern. She has no history of use of alcohol, smoking habits, or drugs intake.
Okay.
Allergy history, she has no known allergy to food or drugs. General physical examination, the patient was conscious, oriented person. She was
Robin, she got disconnected.
Yes, sir.
Oh, I think her signal is little poor. What do you feel?
Yes, sir. So, shall we wait, sir, for 5
Yeah,
minutes?
sure. We'll wait till she resumes.
If you have any points to add till now, you can just add, sir.
Yeah. I think the way she's presenting is good. She has all the details. She has not missed any points so far. Like, let's see what she's gonna present. Like, whether she's gonna present as a breach or there are many types of malpresentations. Like anything apart from vertex is a malpresentation. Like it can be a breach, face, bro.
Please continue, Anna.
yes. So the patient has bilateral pitting edema, which relieves on rest. Her thyroid was examined and it was found to be normal. Her breast has no visible abnormalities. Her spine has no bony deformities. There is no varicosities in her limbs. Systemic examination. CVS S1 and S2 was heard. There was no murmurs. There's bilateral normal vesicular breath sounds and there's no added sounds. In CNS, there was no focal neurological deficits. Abdomen examination. On inspection, the uterus was enlarged longitudinally. Stria gravidarum was present. Linea albicans was present. And linea nigra was present. There's no presence of abdominal wall edema. The umbilicus appears normal. There is no umbilical flattening, and there was no presence of scars. On palpation.
Can I interrupt you now?
Yes, sir.
Yeah. About the vital signs, could you please go to that?
Yes.
Have you mentioned the blood pressure, pulse rate?
No, sir. It wasn't examined.
Okay. These are the points you have to mention, like starting from height, weight, then coming to pulse, blood pressure. Yeah, this is written, like height, weight is written, but pulse, blood pressure need to be checked because the questions may be asked like, how will you examine the patient? Like, how will you check her blood pressure? Like, will you be talking to the patient while, checking her blood pressure, or how it has been done? Could you please tell me if you know?
Usually the patient is made to rest for some time to avoid any false high values due to exertion.
Okay.
And patient is made to sit down or in a supine position if it is comfortable to her. Her hand is kept at the level of her heart, and then we take the blood pressure, sir.
Okay, patient
usually
is
for
down, or the one more thing what you told was?
Sir?
A patient is made to sit down or
It can be examined in the supine positions.
supine position. Okay. Imagine the patient is a term patient, like she feels, little bit breathlessness or discomfort because of increased intra-abdominal pressure, and she's near term. So what you can do is you can make her sit in, left lateral if she's more comfortable, or like you can prop up the bed, because she'll be unable to lie in supine for a longer time, because she has to be like that for CTG. Even CTGs can be taken with left lateral position to make her comfortable, because she shouldn't have the compression. So that's the thing. The first thing is you should make the patient comfortable by not keep on talking to her and not asking any questions while taking the blood pressure. Because there's something called white coat hypertension. So we can avoid false readings by that. Then, as you told, you can keep the BP apparatus at the level of the heart, adequate cuff to be placed. Where will you place the cuff? That is another question.
It's above the cubital fossa, sir.
Okay, above the cubital fossa. Then first, what you will examine?
First, we look at the identify the systolic blood pressure by palpatory method, followed by auscultatory method.
Yeah, we will palpate the peripheral artery, most commonly done as the radial artery. Then after systolic, we'll do the. Then how we will check for diastolic?
It is by auscultatory method, sir.
Yeah. Example, if the systolic blood pressure is around 130, you increase 20 millimeter of mercury and then auscultate. That's how you do that. Okay, it's good.
Okay. On palpation, the fundus of the height, the fundus of the uterus is up to the level of the sternum, and the height of the fundus corresponds to the period of gestation. Her fundal grip, there was a hard, round, independently ballotable fetal part, which is suggestive of fetal head, which is occupying the fundus of the uterus. An umbilical grip, I was able to feel a smooth, curved, and hard, uniform resistance, which was felt on the left side of the fetus, which was suggestive of the back of the fetus. And on the right side, I could feel multiple small nodules, which was suggestive of lymph buds. And the first pelvic grip, I felt a broad, soft, irregular, not independently ballotable fetal part, which was occupying the lower pole of the uterus. And the findings of my first pelvic grip was confirmed in the second pelvic grip.
Okay.
In auscultation, the fetal heart sounds were heard below the umbilicus, and pervaginal examination was not performed. I'd like to summarize my case. My patient, yes.
Like when you're doing examination, like may I know how will you first of all will you introduce yourself to the patient, that, or will you explain her the procedure that what you're going to do?
Yes, sir. So it starts with me being at the right side of the patient.
Exactly.
I'll first seek for the consent of the patient by explaining the procedure to her, the associated risk factors and the procedure that is going to be performed, get her consent, and then proceed with the examination, sir.
Okay, that's nice. Second thing, will you tell her to flex her knee? Flex her
Yes, sir.
Okay, but what position or for the which grip you will do that? While examining the fundus,
yes, sir.
Like you'll tell her to flex the hip and knee. Okay. Before that, what you'll do, what you'll tell the patient, like you've introduced the procedure to the patient, you're standing right side, all done. Before telling her to flex the hip and thigh, what will you ask? We'll ask the patient, has she emptied her bladder?
Yes, sir.
If not, she may go and empty it. If yes, then you can proceed with the examination.
Yes,
then all these things are Leopold maneuver. It's all fine. So what are you coming to a conclusion? Like this patient is having what?
It is a breech presentation where the fetal head is occupying the fundus.
Okay.
And the buttock part is occupying the lower segment of the uterus.
Hello?
Hello. Yes, sir.
Okay. What happened? Okay. Yeah.
The fetal head is occupying the fundus of the uterus, sir. And the
Okay.
buttock of the fetus is occupying the lower pole.
Okay. Yeah. You can continue.
Yes. So I'd like to summarize my case.
Okay.
My patient is a 26-year-old female, Mrs. Vidya. She's a gravida 2, para 2. She has one live baby. Her LMP was on 16th December 2022. Her expected date of delivery is on 22nd September 2023. She, with a gestational age of 9 months, she's come to the OPD for regular antenatal checkup. The diagnosis is, again, she's a 26-year-old female, Mrs. Vidya, with the obstetric score of gravida 2, para 2, live 1, and abortion 0, with the LMP of 16 December 2022 and EDD of 22nd September 2023. The gestational age of 9 months is, and she's found to carry a live single fetus in breech line. With
Live
this, I complete my.
breech line. Okay. Yeah.
Yes. With this, I complete my presentation.
Okay. This is good, actually. All right, Hannah. Then we can discuss about breech then. Before going that, do you have any idea about what is malpresentation and what is malposition? Hello?
Yes, sir. Malpresentation is a. Am I audible, sir?
Yeah. I want to
Yes.
know whether I am audible. Yeah.
You're audible.
Malpresentation is with respect to the presenting part, sir.
Okay.
Whereas position is with respect to the lie of the fetus, sir.
Okay, fine. So, what are the most common malpresentations you encountered in your college?
Most commonly, I've seen breech presentation, sir,
Yeah.
and face presentation.
Okay. What are the other malpresentations which can occur?
It could be a bro presentation.
Okay.
It could be an occipito-posterior position.
No. It's like we are talking about presentation.
Presentations. Okay.
Malposition you're telling is an occipital posterior deep transverse. Okay, fine. But in malpresentation, what else you have encountered? What else could you encounter? Like you have told a bro face, breech. Why can't
Yes,
you
sir.
include shoulder? You can also
It could,
encounter a presentation.
yes, sir.
Okay. Okay then. According to vertex presentation, which is the most common position of the
Left occipito anterior.
Okay. Mostly it is LOT
Yes, sir.
and it is left occipital angle. Okay.
Yes.
But coming to this breech presentation, which is the most common.
Complete breech, sir.
No. I'm telling about this position of breech presentation, which is the most common. Is it right sacro-anterior, right sacro-posterior? Like that I'm asking.
I do not have an idea.
Yeah, the most common is right sacro-anterior. Because they say that the sigmoid colon is in the left quadrant of the maternal pelvis. So it's like the right sacroanterior is the most common.
Yes.
So there are like the main 4 positions of a breech presentation. They say like the first position is left sacroanterior. The second is the right sacroanterior. Third is the right sacroposterior, and the fourth one is the left sacroposterior. So you have to in your book, they'll be clearly given a picture where the baby is lying like in a clockwise position. The pictures will be given, the baby position, like whether it is in the direct sacroanterior or right sacroanterior. That should be memorized, or you may have a slight confusion with it.
Yes.
So the next thing is breech presentation is a type of malpresentation, as you told. Can you explain the definition for breech presentation? Yeah, you can say the definition like how it will be the podalic pole, which is the fetal buttock, which we mainly encounter in breech presentation, or the lower extremities also, because there are like types of breech presentations where you will encounter footling also. So there is this the longitudinal line with the sacrum as the denominator. The in breech presentation it is a longitudinal line. You know that, right? It's not a transverse.
Yes.
So the denominator varies from vertex and breech presentation. So in breech, it is obviously the sacrum is the denominator. And they say
Yes.
like the breech is derived from a word called breeches. Breeches, I think, yeah, breeches. It is the name of a cloth to cover the loin or thigh. So that was just like a history part, how it has been derived.
Yes, sir.
Like, have you seen breech presentation in your college? Like, have you witnessed how they conduct a normal?
Yes,
Okay.
I've seen an assisted vaginal assisted breech deliveries.
Oh, that's nice. That's nice. So, what is a major rule when you encounter breech delivery? The main rule
Um,
is that you should leave it to the nature. It will descend on its
yes,
own. There's no manipulation required. Because in vertex presentation, what you encounter is the head first. So the head,
yes,
the molding occurs, it is a tough process, then it comes out, then comes the shoulder, then later on is the back followed by buttock. It's a gradual process. But in breech presentation, you'll first encounter the buttock if it is a like complete breech. So
yes,
like
sir.
in complete breech, what happens? What is the complete breech? What is the extended breech or frank breech?
So complete breech is also known as flex breech, sir, where the attitude of full flexion or universal flexion is maintained in the baby.
Yeah.
And the presenting part usually has two buttock. It has the external genitalia and 2 feet.
Okay.
The thigh is flexed at hips and the legs are flexed at the knees, sir.
Yeah, that's good. Mainly when you talk about any type of case, for my PG examinations, they were mainly keen on the incidence. The incidence of breech presentation is about, I think, 3 to 4% at term. Hello? Am I audible?
Audible, sir. Audible, sir.
Sure. So,
Yes, sir.
the
Yes,
incidence also matters. So you should pay attention to that. Then coming to the types of breach, like what you've said was a complete breach. That's fine. In which cord prolapse may occur. So may I know the incidence, like how much it may occur? It occurs around like 6%. Okay. Then coming to this incomplete breach presentation. How many types of incomplete breach presentations are there? Like it can be like a frank breach. It can be like a knee presentation where there is extension at the hip joint and flexion at the knee joint. So then comes the last is the footling presentation, which is
so
hello, yeah,
yes,
okay, with the complete or there can be even partial extension of hip joint and also the extension of knee joint. So mainly with this
yes.
frank
We
breach,
have frank breech, which is breech with
yeah,
extended leg.
yeah. My God, what happened?
I think share again a network problem, sir. You can just continue, sir. Meanwhile, she will be joining.
Okay, yeah. So like coming to frank breech, as she told, it is a breech with extended legs. This is actually the most common form. It occurs around like I think 60 to 70% of all breaches. So in this type, there is a flexion at the hip joint, and there is as she told, the extension of the knee joint. it will be like a pike appearance. So then when you do a pervaginal examination, the buttocks and external genitalia are the presenting part. You can feel them. Then it is most common only in primi gravidas due to the extension of legs from well-supported abdominal muscles they may having, because it's the first time they're getting pregnant, and they'll be having a very good uterine tone. There'll be early engagement of this breech in the anal way. Usually breech engages a little bit late than the vertex presentation. But in this, the cord prolapse is very minimal, only around 0.5 to 1%. Then the other presentations are a little bit rare. The footlinks can occur, but the knee presentation is quite rare. The highest incidence of cord prolapse is in footlink presentation, because when you encounter the patient, you can feel the feet outside the introitus. So mostly those patients can be tried a normal, but they can be taken for cesarean if they has any complications. Then in this breech, how will you categorize is the clinical varieties, like it is an uncomplicated or a complicated breech. You can take it like that. In uncomplicated breech, there'll be no maternal or fetal complications. But in complicated breech, there will be some maternal fetal complications. The conditions like the mother can have contracted pelvis, which is a primi, and without any proper obstetric examinations. The further findings, she can have a contracted pelvis. She can have APH, antepartum hemorrhage. Then she may come with the preterm labor, as this patient is about 36 weeks and 5 days. If she has pain, then she may land up like a preterm labor, not like a proper preterm, like near preterm. So then complicated breech is the only indication for elective LSEs, like you can take her for section. Then if she has various other problems, like if the patient present with the extended leg, extended arm, if it's associated with cord prolapse and prolonged labor, it's called abdominal, it is an abnormal breech delivery, but it's not a complicated breech, because in complicated breech, it is too difficult, or there won't be any chance of her to proceed normal delivery. But in abnormal breech deliveries, it can be proceeded, delivery can be progressed. So coming to the cause, if you say, like at around 28 weeks of pregnancy, the percentage of women were around like 24%, where, you know, the patient, though in scan could be seen as a breech, we can wait and it becomes mostly cephalic by 36th week of pregnancy. So if it persists further, then we should take a note and we should say then she's having a breech presentation. So there are some certain, maternal factors or fetal factors which may prevent, which may cause a breech to occur, like mainly in multiparity, not in primi, mainly in multiparity, the causes like uterine relaxation, which is the most common cause. Then comes this placenta previa or any uterine anomalies, like there are some bicornuate uterus, septate uterus. Then if there is any fibroid complicated pregnancy, like if she's having a uterine fibroid in the lower segment, as I told before, contracted pelvis, hydramnios, like polyhydramnios or oligohydramnios. Then a previous incidence, if she has a previous breech delivery, what is the incidence that we should know? So the second breech will be around 10%. Third breech will be around 28%. And there are some more maternal factors. Like there are like some rare like cornofundal attachment of placenta. The attachment of placenta also plays a role. Like, as I told before, like there'll be like placenta previa, or this cornofundal attachment can also do. Coming to fetal factors, then it's like most common is prematurity. In maternal factors, the most common is multiparity causing uterine relaxation, but in fetal, it is mainly prematurity. Then multiple pregnancy, hydrocephalus, coming to all the trisomies like 13, like Edward Patavo and Down syndrome, 13, 18, 21, and IUDs, it can become a breach. Then with the extended leg also. So there's one more thing called recurrent or habitual breach. The thing is, like, if the breach occurs in 3 or more consecutive pregnancy, it is called a habitual or recurrent breach. It is due to, like, if the patient has the uterus has any anomalies, mainly uterine didelphys, septate uterus, and mainly biconvoid uterus, it can occur. So, she has told about the abdominal examinations, what she has done, and mainly breach is felt at the Leopold's third and fourth maneuver. Then one more thing is, like, fetal heart is best heard over the umbilicus, because in normal vertex presentation, you may draw a spino-umbilical line, imaginary spino-umbilical line, and either in the left or right, you can auscultate fetal heart rate. But whereas if in breach, the fetal heart is best heard above the umbilicus, but the breach should not be engaged for that. Then coming to vaginal examination, if you do a PV, you may encounter like a bag of membrane, which is quite conical. Then presenting part is very high, is a little bit higher compared to vertex presentation. In types of breach, the flexed breach, the both ischial tuberosity, anus, sacrum, buttocks and feet, everything can be palpated. Then when there is further descent, there can be palpation of genitals, and we can appreciate that. But in extended breach, you cannot feel the feet, as it is like extended, like hip and knee are extended. Then the footling presentation is also, like, you can easily feel it. When you do a ultrasound examination, like you can confirm and say it like in a primi gravida, like clinically it's little difficult to say in primi gravida. Then you can comment on the like whether the head is hyperextended or any like flexion is there for you to proceed the baby in a normal delivery. Then we can rule out those uterine anomalies, as I told before. Yeah, mostly you can like those maternal and fetal factors can be dealt by a simple ultrasound examination. The polyhydramniotic level, the amniotic fluid level can be measured. Previously, they were doing X-rays, but now it is not done because because of the radiation exposure. Then the main thing about this is the mechanism of labor, how you'll proceed. So the first is, as we have taken the right sacroanterior for the breach, it's the same as the vertex. Like, there comes the engagement, descent, internal rotation of the breach should be told. Then again, a descent with the lateral flexion. Then the delivery or birth of the buttocks can be seen, and followed by restitution. So this is mainly, it's a natural process. You should leave it to the nature, and through the gravity. You don't have to do any traction or kind of any handling. So the mostly in a right sacroanterior, the engagement, as you know, it is a like bitrochanteric diameter. You cannot measure anything else. Like the greater trochanters in the femur, you can measure that. It is around 10 centimeters. And it passes through the internal, inlet of the pelvis. So we are talking about the right sacroanterior. So it is in the sacrum is in the right anterior quadrant of the metal pelvis. And so when the sacrum is in the right anterior quadrant, the bitrochanteric diameter is in the oblique diameter. So there comes the next step. As the engagement occurs, it is followed by descent. And since it is not a hard structure like a head, it is not effective dilator. So it will be little slow and it will take time for it to deliver, the descent to occur. Then comes the internal rotation. The anterior hip, the anterior hip or the anterior buttocks, when it faces the pelvic floor, there occurs a resistance, and so there rotation occurs, like it rotates forwards, downwards, and it's like that. Midline also it comes. Then there's bitrochanteric diameter, which I told, the 10 centimeter part, it will rotate like a 45-degree. First, I told it was in the right oblique diameter. So from there, it takes a 45-degree turn into an AP diameter. It turns on the outlet. So what I'm telling here is, from RSA, it becomes RST, right sacroanterior. The sacrum comes as a right sacrotransverse. So then again, more descent occurs with the lateral flexion of the spine. So these all you can easily encounter. Then coming to the buttock, it is easily visible outside. The anterior buttock, and you can divide it as an anterior buttock and posterior buttock. The anterior buttock. Hello? Hello?
Yes, sir, you're audible, sir.
Okay. See, hey, Hannah, you're like, okay. The anterior buttock, usually when it is the first to descend down. So it is disengaged, and it is underneath the pubic symphysis. You can appreciate by it appears in the vulva by lateral flexion of the the fetal body. So the posterior buttock descends first, which is visible outside. Then followed by the legs and feet can be delivered. Then the last step is this restitution of the hip, and it again brings back the buttocks to the oblique diameter. So you start from the oblique, go to transverse, then again you come out as an oblique diameter. So until these happen, you should not handle the baby. It will occur automatically. But when the difficulty occurs is the delivery of shoulder and the delivery of this after coming head. So you will ask the person who's next to you, who's assisting you, to give a breech towel, so that you can place it over the back of the fetus to prevent any heat exchange. Then in this, as I told before, the engagement of bitrochanteric diameter is around 10 centimeters. Here in shoulder, you will take the bisacromial diameter, which is about 12 centimeters. And it is in the right oblique diameter of the pelvis. As the sacrum rotates from the transverse to right sacrotransverse to right sacroanterior due to restitution. Then again in shoulder, descent occurs. The same step is followed in shoulder too. There occurs like internal rotation of the shoulder, same 45-degree, from the right oblique to the anteroposterior diameter of the outlet. Then again, as you saw the birth of the, the delivery of buttock by lateral flexion, even the shoulders need to be done by lateral flexion. And when you're delivering it, the anterior shoulder will be encountered first. It will be under the pubic symphysis, if you imagine. Then the posterior shoulder and arm should be delivered first by lifting the baby up. So you can the shoulder will be hinged to the pubic symphysis. So as the shoulder is hinged in the pubic symphysis, you have to press it down, and then you have to lift the baby. Then the posterior posterior shoulder to be delivered first, followed by the anterior shoulder. So this method is mostly done. Difficulties may be encountered if the patient is having a diabetes, shoulder dystocia can occur. The pad of fat may be accumulated. So then occurs this restitution, the same 45-degree angle, and the shoulders can be delivered. Last is external rotation of the shoulder to be done, around 1/5 of the circle. It should be rotated. Then once the shoulders are delivered, comes the head. Unfortunately, the head is not that malleable as a buttock. So you should pay attention. Mostly the head will be in suboccipitofrontal diameter, which is around 10.5 centimeters. Or like this suboccipitobregmatic is around 9.5 centimeters. Like it will be like mostly like a right occipito anterior position. So the same steps are followed again. There occurs descent. Then this. So when you see the baby, most of the part of the baby will be outside. Only the head will be engaged. You should not stimulate the baby so that if it starts to respire inside, then there occurs the aspiration to the baby. So we cover the baby with the breech towel. It's just a towel. So this flexion of head occurs, and the flexion of head should be maintained. That is the most important point. There occurs again the internal rotation. Then the birth of the head by flexion occurs. But mainly what happens is the nape of the neck, if you see, it will act as a pivot. The nape of the neck will be exactly under the pubic symphysis. And then when it delivers the chin and mouth, followed by nose, the forehead, bregma, occiput, it is born like that. So this is mainly how you'll deliver like normal delivery. But Hannah, like what can also be done to prevent breech delivery? Can you do some technique before the breech gets engaged? Am I audible?
We have
Hello?
Yes, sir, you're audible.
we have ECVs.
Okay. Yeah, that's what I'm telling. External cephalic version. Okay. So when can it be done? When it is successful? Like okay. Like, I think okay. Dr. Raghu, I think I can't hear Hannah clearly. Like
Yes, yes, sir. Yes, sir. No, your voice is not clear.
my voice is not.
No, Anna, your voice is not clear, Anna.
Okay, I think she should check with the signal. It's okay. It's okay. Not a big problem. So like in external cephalic version, it is mainly about 60% you can have the success rate according to ACOG, American College of Obstetrics and Gynecology. It is mainly performed after 36 weeks of pregnancy. But unfortunately, if you encounter women with 37 weeks of pregnancy, you should carefully examine and you should rule out any high risk factors. As usual, like ultrasound can be taken to estimate the fetal weight and well-being. But that doesn't change anything because until it's not engaged, you can perform it. Then like in you can take her to elective cesarean section because there are some indications why you'll take breech presentation for elective cesarean sections, like mostly all complicated breaches, like as I told before, in contracted pelvis or like the placenta previa, you have to take it for elective cesarean section. Then if the baby is large while doing ultrasound examination, the criteria is like if it crosses like 3.5 kilos or the biparietal diameter is more than 9.5 centimeters. Then if it is a premature breech with the fetus weight of just 1.5 kilos, but it is not acceptable in Indian conditions. Then if there is like hyperextension of fetal head, if she had a previous cesarean, yeah, this point should be told first. the previous history of previous cesarean delivery, then if you can't take the risk that you don't have that much experience in assisting footling or knee presentation, you can take it for a cesarean. Then finally, even the patient's decision matter. Like if she demands for cesarean, then we can take her for cesarean. Then if she has any growth restrictions, like fetal growth restrictions, to be taken. This is for an elective cesarean section. What are the indications for emergency cesarean delivery? Quickly the patient to be delivered is when you leave her for a normal delivery, and when you encounter like there is no progress of labor, non-progress of labor, and if there is fetal distress mainly shown in the CTG, cord prolapse, and mainly the subrupture placenta, you have to take her immediately for section. So there's a trial, like as the presenter name is Hannah, there's something called Hannah trial, like which was done in Toronto, Canada. It is an RCT, it is a randomized controlled multicentric trial. It is like a term breech trial. It compares the planned vaginal birth for breech presentation at term with the planned cesarean delivery. The total amount of people involved were like around some 2000s. The trial finally concluded that planned cesarean delivery has a favorable maternal and fetal outcome than for the vaginal births. The benefits were being greater in countries with if it has a very low perinatal mortality rate. So that's the thing. Then some other trials have also been conducted, like a European study, and this mainly European study was conducted, like a Belgian hospital. So then, so what are the prerequisites for breech vaginal delivery, Hannah? Like what are the indications for trial?
There shouldn't be conditions which are complicated.
Okay.
So if there is, we usually go for direct cesarean in case of cord prolapse in the first and early stages, second stages of labor. So there should be no fetal distress. And
indications of a trial of labor, like rule out cord prolapse and all. Like when will you give a trial for the labor? Like as I told before, like the patient did not have any contracted pelvis, then she should be having an adequate pelvis. That's a point. Like that, I'm asking you. Like the gestational age matters.
Usually for a multi, we go for a trial of labor. A previous history of vaginal delivery.
Okay.
And
like as I told before, in ultrasound, if it crosses more than 3.5 kilos or 3,500 grams, in when you give a trial of labor, the baby weight should be around 1,500 grams to 3,500 grams. Then the gestational age also matters, like 36 to 42 weeks. And like as I told before, the obstetrician should be experienced. Then you should have the support, partogram, CTG should be there throughout the labor. Then scoring, that is the thing I'm going to talk about. What is the scoring system you implement in breech delivery? Can you name the scoring system? Hello? Are you there, Hannah?
Yes, sir.
Is there?
Okay. So it's called as Zatuchny-Andros breech scoring system. Zatuchny-Andros system. Or you can call it as a Weston scoring system. So this scoring system has 0, 1 point, and 2 point. It has like six criteria, like 6 points you should know. Like start from the parity, you should document it, like it's a primary gravida or multi-gravida. So if it's a primary gravida, it is 0 point, and multi-gravida is 1 point. Like that. The other things are like you should mention the gestational age, the estimated fetal weight, previous breech is there or not. If there is any dilatation, then comment on the station. So this Zatuchny-Androsen score, like if the score is less than 4, like there are like 2 scores, like Western score and Zatuchny-Androsen score. In Zatuchny-Androsen score, If the score is less than 4, then the cesarean delivery is recommended because of risk of fetal morbidity and prolonged labor. So by that you can take the patient. Like then what all you'll notice in breech? What can also be given to ease the patient in labor?
Episode,
Yeah, you're close. It's no.
epidural analgesia can be given since usually the duration is prolonged,
Okay.
and episiotomy can be given to prevent any tears.
Yeah. That's a good thing. Then what else can be avoided in breech? In augmentation of labor with oxytocin can be avoided. That is another thing. Mainly you can put partogram also. So they have told during the first stage of labor and second stage of labor. The first stage of labor, as you told, like you can comfort the patient, encourage her for vaginal delivery. You can do a vaginal examination. Then you can hydrate the patient mainly with ringer lactate or dextrose. Then, as usual, the blood samples to be given for all the hemoglobin status. Then epidural analgesia can be given, partogram can be given. Okay, you can rule out cord prolapse. Then you can avoid this augmenting oxytocin too. What happens in second stage? So you can leave the patient as a spontaneous breech delivery, or you can do an assisted breech delivery, or there can be something called breech extraction.
Yes.
Yeah. So and what else? It's like, okay. Can you tell me some complications in assisted breech delivery? What happens?
Usually
Breech
there
delivery.
can be premature rupture of membranes, sir.
Okay.
There can be head entrapment, prolapse of the umbilical cord.
Okay. Okay.
There can be difficulty in delivering the aftercoming head, or it can be an impacted breech, sir. There can also be difficulties due to extension of the arms or legs. And in certain cases, there are also nuchal position of the arms.
Yeah, these are the things mainly. Yeah. Okay. Then can you like can you tell me the procedure when you're conducting this breech delivery?
Yes,
Like I've told you about this thing, right? Breech towel.
yes, sir.
Can you explain why you want to put that breech towel? What
Because
type of maneuver it is called? It is called as Savage maneuver. So why does
the exposure of the baby's skin to the air can induce breathing in the baby, sir, which can cause aspiration.
respiration followed by aspiration?
And it can also lead to hypothermia in the baby.
Okay. But for an obstetrician is mainly to make it easier to hold the baby because it will be so slippery. You cannot just like that hold the baby because it will be covered in that amniotic fluid. So you should not drop the baby.
Yes.
That's the main thing because the neck will be very weak.
Okay, sir.
So then, okay, coming to the techniques, like what are all the techniques for the aftercoming head? Can you name them? Or can you tell me the most common technique for when you're doing a breech delivery?
So we have three methods. So we have the spontaneous breech delivery, the assisted or partial breech extraction, and then we have total breech extraction.
No, those are fine. But like, have you heard about the techniques like Bun Marshall technique or like during the delivery of aftercoming head? Like, have you encountered the word called the curve of Cavus?
Yes, sir.
Then this what is it called? Morrison's smelly weight
Smelly weight method. Yes, sir.
maneuver. Then one
Yes,
more thing, the drag maneuver. Have we encountered them?
yes, I've seen Mauritius weight methods, sir.
Oh, that's nice. They have
Where,
done in your college.
yes, sir. Yes.
Okay, so how will you do that? Could you please explain?
So here, usually the fetus will be supported by the left forearm, and the index and the middle finger will be applied to the maxilla of the baby. So which will help us to flex the head of the baby. And then the index and the middle finger of the right hand will be slipped over to the clavicles from the behind, sir. And we give downward traction
Placing your
till the
left,
nape of
like on top of your left hand, the baby is lying. Okay.
yes, sir.
Then you're telling you're using the right hand to something with the clavicle. You told me, right? Like
Yes, sir. It is used to slip over the clavicle from behind, sir.
you cannot do that because the baby will be facing down. Like
Yes, from behind we are doing it, sir.
yeah, but like with the right hand, you can place it on the fetal back only. Like you cannot
Yes,
place it in the clavicle because already the left hand is encountering all those.
yes, sir.
Hmm.
Yeah. So we apply downward traction till the nape of the neck is appearing.
Okay.
And after that, we change the direction of traction and we swing the fetus over to the mother's abdomen, sir. And we
Okay.
also apply suprapubic pressure over the head, sir.
Okay. So how many people you need when you're doing this technique? Minimum 2.
Yes,
Yeah. So the main thing in this Morrison Smelly method is it uses the fetal back and it should be in anterior position. The fetal back should be facing you.
yes, sir.
This technique is mainly for like fast delivery. Even you can do this method even without any assistant too.
Yes,
Then, as you told, the index finger, middle finger, it's applied over the malar bone, like the maxillar bone on both sides of the fetus, which is mainly to flex the head.
yes,
That's
sir.
why you place the baby in your left forearm, and the hands are like with the index and middle fingers over the maxilla, and you can flex the baby head. Then with the other, hand, you can place it over the back, and with the middle finger, you can be you can push the occiput to promote flexion as you are using your left index and middle finger to on the maxilla to create flexion. You can even use your right middle finger to push the occiput to promote flexion again. So
Yes,
then like when you keep the middle finger and the occiput, the other two fingers like the index and the ring finger could be placed on the shoulder. Then, as you told, the downward traction can be applied. And if you have an assistant, you can tell them to put the suprapubic pressure.
yes, sir.
Okay. Then what do you know about any other methods like Prague method or the famous Bun Marshall method?
Mm.
Okay, there's nothing like the Bun Marshall method. Like the fetus is allowed to hang on its own weight. It,
Yes,
it should be like completely unsupported. Then this needs an assistant mainly. The assistant will be, before you, they'll be giving a suprapubic pressure.
yes, sir.
Then it will be like for during every contraction, it goes like downwards, backwards direction. Whereas in the method which you told before, there is like a like downwards traction to be given, irrespective of the contraction. But here you should give according to the uterine contraction, downwards and backwards direction. Then there occurs this engagement of fetal head. So then, as the obstetrician encounters those, infant leg, we can pull it with the right hand. How you'll pull it is like you can place the middle finger, between the two ankles, and you can lift the infant towards the mother's abdomen, like swinging, like an arc. You can do
Yes,
that. Then again, the head is extracted by traction on the, like while swinging the arc, it is like head is being extracted. Further you can cause like suprapubic pressure for the flexion of head. It can also ease the delivery. But whatever you do, you should not do it with vigorous force. That's the main thing. And how about forceps? Have you encountered forceps? Like, what are the types of forceps? Outlet forceps.
Yes, sir. So we can use outlet forceps to deliver the after coming heat, sir.
Okay, yeah. But again, care should be taken. Damage can occur.
Yes, sir.
So mainly they'll ask you in Viva is which is the left forceps and which is the right one. So first, which forceps will be introduced? So first, which forceps will be introduced? Is it the left or the right?
The
It's the
left forceps.
Yeah, it's the left forceps, correct. So they may ask you about the pelvic curve, the parts in the forceps. They can ask
Okay,
you.
sir.
Yeah, you can know these methods. Then about the trial of labor,
Yes, sir.
since it is like the pelvis is adequate, you can allow her. Okay. How about in frank breech extraction? What maneuvers you'll use? Mostly one maneuver you'll use. It's a Pinard's maneuver. But in this, you can give general anesthesia to the patient. That's better. Then what are the other methods like there's
Lot
something
of low sets manuals.
exactly. Do you know about Lowset maneuver?
Yes, sir. So it's usually done to bring down one of the arm of the baby. The trunk can be rotated for a 180-degree by keeping the back anteriorly and by maintaining a downward traction, sir. So we do a clockwise rotation to deliver the left arm and an anti-clockwise rotation to deliver the right arm, sir.
Okay. What you have told is nice, but mainly this Lowset maneuver is the method of choice for delivery of shoulders.
Yes,
If the fetus is having extended arm, or what you told before about the nuchal arm. So
yes.
in those methods, we can use the Lowset maneuver. And it is also used in this assisted breech delivery. The Okay, other things I think you told clearly, like you have to rotate it, and so that first the anterior shoulder comes, then the posterior shoulder comes next. What happens like if the fetus is dead when you're dealing with an IUD baby? How you'll extract the baby?
We can go for complete breech extraction.
Okay. Or you can use some instruments to pull the baby. That's okay. Yeah, mostly these are the main things you need to know. Then okay. Coming to this, if there is like cervix, if there is no dilatation, what you can do?
Uh,
Like what I'm telling is
um,
arrest of after coming head. What are all the methods you can use? I am particular about the cervix, but you can say even other methods like what can be done.
Usually a cut is given at the cervix.
That's what I want to ask. What is the name of that incision? It's called like Dusson's incision. Like if I'm the spelling is Durssen. Dusson's incision. Okay. So where you'll put the
Yes,
incision? At what?
is usually at the 6 o'clock or 10 o'clock position.
Okay. It can be even 2, 6, and 10. Okay.
Yes,
Mainly used in this after coming head of preterm delivery,
yes,
because there will be the head will be bigger in preterm babies, and irrespective of molding it will be difficult to come out. So while doing this, how can you extract an IUD baby? You can do a craniotomy.
yes.
Yeah, then mostly that's all. Like they may ask you like X-ray appearance of the fetus. It will be in a stargazing sign, stargazing fetus, right? That is another thing. Okay, then you tell me the injuries which can be encountered after breech delivery mainly.
Can
Most,
be due to instrumentation, sir.
what are the most common injuries the fetus can be encountered?
Erb's palsy, sir, due to hyperextension of the shoulder.
Okay,
And injuries to the fetal skull due to excessive molding,
okay,
which can lead to intraventricular hemorrhage, sir, intracranial hemorrhage. Can also lead to intrapartum fetal death
okay,
or birth asphyxia, sir, due to cord compression.
okay,
And there can also be birth injuries because of manipulative procedures that we do, where
okay,
there can be hematoma, fracture, usually of femur, humerus, clavicle, and there can also be dislocation of the hip joint or cervical dislocations
okay,
or epiphyseal separations. There can be visceral injuries, so rupture of vital organs like the kidneys, livers, or lungs. And there can be hemorrhage of the testicles if it's a male baby. And talking about nerve injury, it can be a spinal cord injury or medullary coning. Excessive stretching of the shoulder can cause brachial plexus injuries. It can be either Erb's palsy or Klumpke's paralysis.
okay,
And it can also lead to other long-term neurological damage.
okay. When you're doing this smelly wit technique, like unfortunately, if you touch the mandible instead of you know the maxilla, what happens?
Yes.
There occurs like mandible fracture.
Yes.
So that can also be there. Even other bones can also be fractured in breech delivery.
Yes.
Like the baby can also encounter intracranial hemorrhage too. So what do you conclude by this
We
breech?
can go for a conversion of a breech presentation to a cephalic presentation if
Okay,
there are factors favorable for external cephalic version, thereby reducing the incidence of mortality and morbidity and fetal complications. If we proceed for delivery continuing with the breech presentation itself, it is
okay,
very vital to have experienced obstetricians who will be able to conduct the delivery, and you should also rule out maternal factors. In
okay,
case of absence of skilled or inexperienced people, the medical personnel,
yeah,
it is ideal to opt for an elective cesarean section.
exactly. That is the main thing I want to say. Like you should not stress the patient. You can take it for an elective cesarean section, but care should be taken. You should know like whether you have all the facilities to do the procedures. So that's all. Like this is nice, and that's what like breech presentation is a very good topic because in even for PG exams, it can be given as the mannequin. Mostly while asking normal delivery, they may ask about even the breech delivery. So you should be keen in practicing that. You can do that in your college. Like there'll be dummy pelvis. You should know how to hold the pelvis. Then again use a toy, and you should know whether it is a right sacro-anterior or a right sacro-transverse that should be dealt. That's all. Mainly, this is what breech presentation is, and it's a good class. Thank you, Hannah. Like it's a nice case that you presented.
Thank you, sir.
Thank you, sir. Thank you so much. It was a very brief and elaborate discussion. If you have any doubt, you can just put it in the chat box, or after the session, you can just put it in the comment section so that we will be able to clarify it. Thank you
Yeah.
so much, sir, for joining with us today. And we hope so we will have more sessions in the upcoming days. Thank you, Anna, for giving a wonderful presentation. If you have any doubts, you can just clarify it with sir, or you can just post it in the group so that we will be getting it clarified from sir. Thank you so much, sir.
Yeah. Thank you all. Thank you. Take care.